So now we are using the biomechanical in a new area. You already have a patient that has been treated, and you would like to know if this patient will be stable over time or not, or have taken some risk. So that is my financial disclosure. Our story. This is a group where we start to work together with large number because we have the idea that biomechanics was so important. So it was a journey where we remain friends, we have a lot of discussion between us, but all us think that the biomechanics can help so much in managing the patient. So the fundament was to understand how was the IOP, because first of all you are measuring IOP when you use the air path. So you have a lower IOP, the deflection amplitude is much higher, so we need a correction. And then we look for the normality values, then the CBI, then the TBI. And so now let's go to a new topic, laser visual correction ectasia. The incidence, how can biomechanics help? This is the outline, the aim of the study, methods and material, the new CBI, and result, and conclusion. So, laser visual correction is already widely accepted by the ophthalmology community, and even if an excellent safety profile, however, we still faces some patients who develop ectasia, regardless is PRK, SMILE, or LASIK, that is still active problem. So the early detection is very important. Why? First of all, because if you can treat in advance those patients, you can freeze the condition before more severe complication. And second, because if you just have a suspect, you have a closer follow-up of those patients. So up to date, the gold standard for LASIK vision ectasia detection can be performed, and we will see how to do. The incidence is very low, but the effect is devastating on your practice because the patient is complaining, is reporting very bad outcome. And I remember once in the American Academy of Ophthalmology make a survey asking to ophthalmologists, why for you the refractive surgery is going down in numbers? And what doctor answered? Because cost too much, because there is pain, I have to stay away from work, and many other issues. Then ask the same to patient, and this patient answer, I fear the risk to become blind, I fear halos, if I have a complication, who can fix me? So even if the incidence is lower than we fear, but the impact on the patient community is very high. So being able to detect this changing very early instead of year after is important, because remember, you can have a very early ectasia, but you can face the ectasia 7 years after, 8 years after. So detecting early is very important. It is important that even if the incidence of the ectasia in SMILE is lower at the moment, we have a small number than LASIK, is still present. And LASIK extra do not show to be a safe gate to avoid an ectasia. So, of course, we want to non-nocere to anyone, from what we learned from Hippocrates. So, as we know that the primum movens, as Cinzia pointed out, and also all the new findings, the Brillouin microscopy and so on, is the primum movens is the biomechanical, why we cannot look this to avoid any or reduce the iatrogenic damage. The implementation of corneal biomechanics could help in detecting this. Which are the challenges? First of all, we have to separate normal from keratoconus patient. Then we should be able to stable laser visual correction from abnormal TBI and CBI, and then to be able to separate stable laser visual correction from ectasia. So we need a large database and a semi-automatic approach. This is a new team because was a very challenging idea, and we increased the team to increase the database, to increase the differential races, and so on. So that's what we use, the Corvis. I do not go through everything that Cinzia already covered, the phase of the Corvis, and we create a new version of the CBI named CBI-LVC for laser visual correction that aims to separate stable patient after laser visual correction for patients who can develop ectasia, and to validate this with a big data set. The population was more than 4,000 patients, were enrolled from different continents to include a high number of patients with different ethnic groups, and the patient included was healthy, keratoconics patient, stable post-laser visual correction, regardless the type of correction, and ectasia that coming after laser visual correction. The population detail, that is how many normal patients, how many keratoconic patients, how many stable, and how many with laser visual correction. Of course, the inclusion criteria should point out that in healthy eye, no previous ocular surgery, no myopia greater than 10 diopter, no concomitant previous glaucoma or hypotonic therapies, and Bering-Ambros index better than 1.6. Keratoconus should be bilateral, no previous ocular procedure like cross-linking or intracorneal rings. Stable post-laser visual correction, at least 1 year of documented stability, surgery done by a non-refractive surgery expert, and laser vision ectasia, all diagnosis confirmed by masked cornea expert. Only Corvis examination with good quality scores, some experienced technician and captured by automatic release, and second manual frame-by-frame analysis by independent masked examiner. Logistic regression was employed to determine the optimal combination of parameters to be able to have a semi-automatic classification of. That is very important because now we have a large cohort and the system should be able to separate only by CBI, only by biomechanical, which is the healthy from the laser visual correction and keratoconic patient. Then, a second step, to separate the keratoconic patient from laser visual correction, regardless stable or not. And the third step, to create a second analysis to create a separate stable visual correction from ectasia. To avoid overfitting, 80% of the database for use for training and 20% for validation. The statistical analysis, we have starting from the data set should be separate normal from abnormal, then keratoconic and laser vision from separating laser vision from keratoconic and laser vision stable from unstable. Step 1, an updated version of CBI aimed to separate it. That was the index that we use. The Cinzia already covered why we choose those parameters to being able to separate. That is the step 1 was the training and the validation system. Sensitivity in the training was 88, specificity 94. Validation, sensitivity 87, specificity 97. Step 2, CBI aimed to separate cross-link keratoconic patient from laser visual correction, stable and ectasia. That's what we use. Highest concavity arc length, A1 velocity millisecond, Pack's slope in micron, deformation amplitude maximum, the first applanation deflection area in millimeter, integration radius millimeter, and peak distance 1 millimeter. The final version user will be asked to confirm whether the patient has laser visual correction. To increase sensitivity, we will ask at this step to the examiner if this patient has laser visual correction or not. If you do not respond, can do anyway automatically, but you will see why it's better to inform the system. The training is 89 sensitivity, specificity 94, the validation 90 sensitivity, and specificity 96. Step 3, aiming to separate stable laser visual correction from ectasia. And that was the used parameter. Training set for this step, for this phase, 95 sensitivity, specificity 96, validation, sensitivity 90, specificity 98. Now, the overall classification, a fully automatic classification of fork group, if you would not to be the case, if you do not know, sometimes someone comes to you and you do not know if he has ever had a laser visual correction. For surface ablation, even OCT do not help you that much. If we do not have a fully, if you do not inform the system, 87 correctly classified in the training set, 87.5 correctly classified in the test set. Remember that you inform the system if you have laser visual correction, the sensitivity moved to 90, specificity to 98. To our knowledge, that is the first time that only biomechanically we are able to separate all this group of patients with one single exam. And the present of external validation dataset confirmed that this finding and exclude overfitting, and almost fully automatic classification based only on biomechanics is possible. Now, when could be useful? Of course, if you detect a patient immediately after refractive surgery that could have risk to develop at a later stage ectasia, will be very helpful because you will have a closer follow-up or you still decide to have cross-linking. Evaluate if the regression is a corneal biomechanical weakening or is a starting or is a regression. A regression can come later stage with epithelial hyperplasia or new tissue. Or before retreatment, you can decide it is a risky patient to be retreated or not. Clinical practice. Now, we have this patient with this condition. We start to make the analysis, and this is in clinical practice our screening report. CBI is in the red. Now we are asking, is this patient post-PRK, post-LASIK, post-SMILE, post-laser visual correction, but you do not know which, or no laser visual correction? When you answer, BED-D and TBI is graded out as not working because only biomechanical evaluation, and here you have the index that is working exactly. You activate, you can see here if it's untreated or post-laser visual correction, so there is a reminder of your answer, and so you can understand what is the case. If you post-laser vision correction recognize it, and then you have the grade post-laser visual correction. Now in ectasia report, always the confirmation, and then you see, even you immediately see the risk of ectasia because the cutoff is 0.5, and here you can see it in the red area. So everything is summarized here, as you see, and biomechanics can be able to add another step, a safety step, to your surgery, being able to detect before. Because always remember, assuming that you have a patient, you have performed a LASIK, and you detect that this can risk or already starting to have an ectasia, someone comes to you with a suspect eye and you detect that it's an ectasia, is very different for a patient to be underwent to cross-linking or a DALK, particularly for the low sweet problem. A cross-linking is accepted, a DALK a little bit less. Thank you.